multiple ways to increase the rheumatology workforce in India, Pakistan, and even studies from Bangladesh. But those are the countries where there are facilities for rheumatology training, whereas in Nepal still we do not have proper rheumatology training facilities. This is a slide I borrowed from Professor Nigat Ahmed from Pakistan as he presented this in 2020. The scenario of rheumatologist per 80,000 population. The recommended is usually 2 rheumatologists per 100,000 population. With this reference, it was seen that there is a huge gap in the number of rheumatologists, and India has in the recent few years has a rapidly increasing number of rheumatologists, but on population basis still, even if the number is in thousands, per population ratio is still 0.07 per 80,000. So coming to the situation in Nepal, I'd like to show the condition of musculoskeletal health in Nepal. This is the Copper survey. We have completed the first phase recently. Among the 7 provinces, we did the population-based study in province 3, where the capital city also lies. The musculoskeletal condition prevalence was around 25%, with pure rheumatic, definite rheumatic diseases, including osteoarthritis, of course, was around 14%. And soft tissue rheumatism and mechanical pain only was seen in around 8% of the population. So, these populations are catered by doctors. The overall doctor to population ratio, the recommended is 1 doctor at least for 1,000 population. The population prediction, as we can see, this is the prediction that given, they have given, this is the government data, till 2030. And still, with the projection till 2030, we still have inadequate number of doctors overall. Rheumatologists are just a small part of the overall doctors population. This is the data I've taken from Nepal Medical Council, and we've seen that around 948 physicians, internal medicines are registered with the council, and of them 19 are rheumatologists. Other specialties are mentioned because MDGP and orthopedics are often the specialties who are the point of contact, first point of contact for patients with musculoskeletal and rheumatic problems in Nepal. So, with the recommended per population, per 100,000 population of 2 rheumatologists, we currently have 0.06 per 100,000 population. And in further slides, we will be discussing the demographics of these this small population of rheumatologists which we have. So this is the most accepted systematic research review, which gave the median of 2 per 100,000 population, and it is still based on Western data, but is widely accepted. So we conducted a survey through Nepal Rheumatology Association. This was a structured questionnaire adapted from the Australian Rheumatology Association workforce survey and adapted to the Nepalese scenario. This was an online Google form, and the link was sent to all rheumatology practitioners. The link was also sent to other specialties, but the response was very poor, so I'll be analyzing only the part from the rheumatologist. The age group is mainly between 35 to 44 years, around 90% of rheumatologists are in that age group, which is in contrary to what has been seen in the Western literature, where the retiring age group population was more. Also, 15 were male, that is around 80% of the doctors, rheumatologists are male in Nepal. Again, in contrast to the increasing female participation in the subject in the Western literature, which they have shown. The alarming factor actually is the third part, where of the 1916, 84% were concentrated in the capital city within the valley. This is the visual representation where all the stars seen in the top above province 3. It's not only in province 3, it's the small circle that you can see, it's the small valley in between. That area has a population to rheumatologist ratio of 2.1 is to 100,000 population. But in other areas, you can see the reach is very, very less. There are few, 2 or 3 started rheumatologists in other areas. But then they do provide satellite clinics. There is outreach clinics in the peripheries, like in weekly or monthly basis. But still, this is grossly inadequate, and as you can see, These are the sites. White stars represent the areas which are covered by the outreach clinics, and there are still large proportion of land that is still untouched by the service of rheumatologists. And most of the areas which are still not touched are in the upper hilly and mountainous regions. So this is another survey with this kind of geographical distribution of the workforce. We studied the healthcare seeking behavior, which is our patients with rheumatic and musculoskeletal disorders, and among 390 respondents, we saw that the median lag time from first visit, first symptom to visit to a rheumatologist was around 12 months, varying from 5 months to up to even 4 years. Their first point of contact to GP or healthcare worker was around 6 months, and after consultation with the GP, the referral median time was 2 months, which is really appreciable. So done. If there are proper opportunities, facilities to a doctor, decentralization is likely to happen. Otherwise, with nature, as there is super saturation in the center, gradually people will start moving to the periphery. So this would come with time. So my conclusions are, this is vastly inadequate as expected. It is gradually increasing, the good news is, and is not expected to decline in near future. The proper use of technology can help us tide over the immediate crisis, and the trained manpower as well as triage manpower, if you can train them, as I call it triage manpower, who can at least identify more severe diseases, it would strengthen the workforce in the long term. Also, we are planning to have a second International Rheumatology Conference in Nepal in February, tentatively 3rd, 4th. The posters will be out soon. I'd like you to visit the country. Thank you.
Thank you, Dr. Binit, for your excellent talk.
They could not find a rheumatologist. So unawareness and unavailability were the main causes of the delayed lag time. And by that time, what did they do? They used the complementary and alternative medicine. There's a very prevalent thought and myths in the communities about various types of diets and to avoid and to eat, and various other Ayurvedic or so-called pulverized steroid formulations that the patients are taking. So around 50% of patients who came to us were actually in the lag period were doing either form of these kind of therapies. This again was an interesting survey we did in the western hilly region of Nepal. There is a natural hot water spring. It is called Tatapani, and the place is famous not only in the area but overall in the country. And we could see the crowd of people dipping in the hot water with the hope that they will get rid of arthritis. And even that place has been so developed now, there are lodging facilities and they are staying for weeks with that expectations. And in this survey we found out that the beliefs are really deep rooted, and even though people do not believe the concepts, they still want to try, no harm being done. They want to spend time and they want to try the hot water spring. But they were unaware of the subject called rheumatology. So coming back to our survey, now of this, the rheumatology population which we have is mainly distributed in the private sector, which is again an alarming finding. We saw that 100% of rheumatologists were affiliated to private sector. Of them, 57.9% were solely working in private sector. There's no person fully affiliated in government sector. Few of them were affiliated part-time as private and medical college or government sector. This is the government data again, which shows that for private facilities are only 29.8% among all the health care system. But for rheumatologists, almost 100% of them are involved in private health care. Annual income, approximately monthly income was 50,000 to 2 lakhs Nepalese rupees. And this interesting finding is the lower part of the table. We can see that The people with 5 to 10 years or more of experience and those with less than 5 years of experience, the number of people are almost equal. So it shows that as the seniors are growing, the juniors are joining in. Even in last 1 year only, there are 4 new rheumatologists who have joined. And most of the rheumatology degree holders are fellowships, and most fellowships are from India. There are 2 DM rheumatology specialists, and they are from PGI Chandigarh, and 5 MD rheumatology from Bangladesh. So still the majority are the fellowship holders. This we try to calculate the full-time clinical equivalent. One full-time clinical equivalent is considered as 8 hours, and per week we can see that both in metropolitan and non-metropolitan area, the clinical full-time equivalent is much higher in the private sector, and in public sector, the clinical full-time equivalent is much less. So even they are affiliated, more time is being devoted to administrative or other teaching activities. Most doctors were seeing 100 to 200 total patients in a week. 20% new patients were usually accommodated in their weekly patient schedule. Average waiting time, again, this is good news. We saw that no new patient had to wait for more than 1 month. Mainly, most patients, they had a waiting time of less than 1 week. That means, despite the patient load, the efficiency of doctors are increasing. And the nature of clinical practice, most are involving adult rheumatology care. But they did admit that they also see pediatric rheumatology cases also, because there is only one pediatric rheumatologist who was recently came back after studies to Nepal. And because there is no single dedicated rheumatology department in any of the government or medical institution, all of them are under internal medicine, and all of them are also seeing non-rheumatology patients. And that is definitely going to take some part of their time, full-time clinical equivalent. So, though we had an idea that no one is going to retire so soon, but we wanted to have some fair idea of what is going to happen in 5 to 10 years. The good news is, all of the 19 people were not considering retiring completely, whereas 9 rheumatologists were at least considering reducing their work hours. 2 rheumatologists were considering completely ceasing rheumatology care within 5 years, but we did not ask why. So at least we know that in 5 to 10 years, the workforce is gradually going to add up and not going to decline. To increase the community outreach, because as I showed in the initial slide, the peripheral outreach is very, very less, and only with 19 rheumatologists, only 4 or 5 areas are covered. So we asked them, what is the single most important factor that will motivate you with your commitment for a rural outreach? The financial support was the main factor. So maybe it is the effort, cost, travel, stay is not cost effective to provide service in the rural area when there is absolutely no government support. Few responded that a place near airport is preferable, and few wanted someone to assist them with teaching as well as learning. And about rheumatology training of healthcare professionals in the peripheral area, 17 doctors were interested. This is a multiple option question, and 70 doctors were interested to train the local GPs or doctors if there was opportunity, time or place available, so that the peripheral trials and screening is at least possible. 3 doctors were not interested in teaching. 6 said that they can even manage with training nurses for clinical assessment. For follow-up assessment, we can use telemedicine, because always rural outreach has a problem of monitoring of disease activity, side effects, and especially if there is some drug toxicity, it is very difficult to manage when you visit places on monthly basis and rural places. So we asked if telemedicine was a preferable approach. 4 were already using, 9 were positive if a suitable platform is available, and 6 doctors did not prefer using telemedicine for rheumatology follow-up. Research is very primitive in Nepal. We do not expect a groundbreaking molecular level research, but however we are building data on the population prevalence at least, and the patient demographics of our own nature from Nepal. and it's seen that most of the researches are being done in private centers and in public, hospitals or medical colleges, it is usually done as a part of thesis. Most of them were not funded. Two researches were ILR and APLR funded. So the possible solutions that we can have for this manpower crisis in rheumatology, we could obviously think of using technology. This was an ILR project done back in 2018, where we tried a web-based rheumatological training. We developed a module. 3 or 4 people, rheumatologists, sat down and prepared a basic module for approach, diagnosis, treatment, and monitoring. And we did the web-based training. And along with the web-based training, whenever we did the setup for that training, we also tried to make another session for patient education and interaction program. Results were interesting. Doctors, paramedical staff, health assistants, everyone participated. But we saw that we did a pre and post test. Basic questionnaire was there, and we did pre and post test screening after the training. We found that the scores of doctors did not improve, or rather sometimes reduced after the training. Whereas the scores of paramedical staff, health assistants, they improved drastically. So we presume that maybe the doctor's baseline knowledge was enough in the first. The training was too primitive for the doctors, and there's nothing more to learn. Maybe that was the reason. But this was one model, and we adapted this model from our center to start a web clinic. And this place, which is in the western region of Nepal, at an altitude of around around 7,000 feet, 7 to 9,000 feet, so 372 kilometers, takes around 12 to 15 hours drive. So we started using this model. This is not a direct telemedicine. Direct telemedicine also consumes a lot of time. You have to connect issues, and you have to give a lot of time to patient, and telemedicine usually takes more time than the OPD clinic actually. So this model is basically training of the healthcare professional who is available at the place, and we will just monitor in the background with all the data sheet that we have provided them. They will fill it up and we will monitor it. And gradually the patient acceptance is gradually improving. There are some teething problems, obviously administrative issues are going on. Otherwise, after sorting out this pilot phase, maybe we can expand such kind of model to rural places where vehicles cannot reach, but internet is obviously there. So maybe this is one solution that we are thinking of. Obviously, long-term solutions could be increase in training opportunities in rheumatology. India has been training a lot of centers, has been training a lot of doctors from Nepal, and we would love to have a structured training program in Nepal itself. One institution in Nepal has started fellowship program, and I think it is not adequate, and we will like to have more, and obviously academic support has to come from the neighboring countries. Short-term training of healthcare professionals as a primary contact, like MDGPs or medical officers or paramedical staff. We did a informal survey among them also, but most of them they were very interested in getting a training, but they wanted a duration not more than 6 months, preferably 3 months. So a module that trains to screen the diseases within 3 to 6 months is very hard to make. Recently, I think BMJ has produced a model on an online course, so maybe we could adapt something from that. Decentralization of workforce obviously is easier said than